again for coming today. And I'm going to reintroduce Brian, my husband and I, and we have been facilitators of kitchen table conversations for several years. I want to especially thank today Missoula Community Access Television, who is taping this, and you will have access to it on their cable station. This is part 2 of our workshop, and so we really appreciate this as a media assistant grant, which was donated to Missoula Aging Services. We also want to thank Missoula Food Bank and Community Center for this wonderful venue. It's truly amazing. So I would like now to introduce our panel members. First of all, I want to introduce Beth Ammons. Dr. Beth Ammons is a native of Missoula. She graduated from the University of Utah School of Medicine in 1988, and after finishing her family medicine residency in Phoenix, Arizona, she returned to Montana to practice family medicine in 1991. She has practiced in Polson, Whitefish, and Missoula. She currently works with Partners Hospice as Associate Medical Director since 2002. She is board certified in hospice and palliative care, as well as family medicine and integrative medicine. We also have Dr. Dick Blank, who we have met before. Dr. Blank went to the Medical College of Wisconsin, go Packers. For 39 years, he had a career mostly in diagnostic radiology. More importantly to us is that he was a caregiver for his wife during a 10.5-year journey with early onset dementia. He is a member of several groups in Missoula, including Dementia Friendly Missoula, also the Montana State Plan. He's an active volunteer with Missoula Aging Service, mostly with Meals on Wheels program and with the resource group. He also meets individually with dementia caregivers to help them deal with the complex journey of dementia. And then we also have Gail Kerscher, registered nurse, who is active for 40 years, working mostly in critical care and home health. She is now retired and lives in Missoula. She has worked at Community Hospital in the ICU for 14 years, in pain management for 9 years, and she has worked at Partners Hospice for 13 years. She's a very active Missoula Aging Service volunteer. Thank you. I'm going to begin this program just asking each of them one question. And that's just going to be kind of an introductory question. And then after that, the group will be able to ask your own questions. Starting with Dr. Ammons. What is palliative care and how is it changing medicine?
Well, the way I think about palliative care, what is palliative medicine? Thank you. Palliative care is care when there's a life-changing, life-altering illness, and it's a chronic illness. So everyone is aware that this will change the trajectory of their health. Palliative care starts when that can start when that diagnosis is made. And one of the advantages of having this concept and this availability is that I believe in the best case scenario that there is a very strong relationship between a patient and their doctor. I have worked with the resident doctors over a partnership, and one of the things that we emphasize there is relationship. with the patient. And what this means is that you have conversations like you're being educated about today, you have them very early. My story is that, gosh, it's 10 years ago, I gave my family a 5 wishes document to fill out for Christmas. Because, you know, I've just seen, over 30 years of being a family medicine doctor, I have seen things happen. You can't always predict. And I have personally some pretty strong opinions about what I am willing to either put myself through or my family through if there is a sudden event or if there's a chronic event. The other thing that's really important about palliative care is that it's similar to hospice in that a full palliative care program will have the supports pretty close to what hospice has. Right now, we're doing a pilot program with Medicare, and we're only using 4 diagnoses, and we have a program that does not have as extensive support as our Partners Hospice does. But it's trying to figure out how to get this to happen when people first get diagnosed. For instance, the first time they have congestive heart failure. The first time they discover their kidney function is in the toilet. And it allows discussion about your wishes, about your goals. And it's really important as a part of that to continue to revisit these as you know life changes. So disease states change, families shift, and it's really extremely important that there's open discussion if possible, and that we revisit what are our goals, because they change over time. And so that in a nutshell is palliative care, and it basically is an umbrella, and underneath it is hospice care, which is regulated by a prognosis, an expectation by a physician or physician extender that in their best judgment, medical judgment, there's only 6 months left in this person's life if things will continue to go the direction they are. So that's a big difference, because palliative care covers you well before that. And I think it's the best kind of care that we could have over a partnership. When I work with the residents, we really emphasize having these discussions way in advance of a crisis and looking at the whole person. And in that creamery building where the Partnership Health Clinic is, we have behavioral health, which allows us to have a resident doctor see a patient, and if they need to be talked to right then about some sort of mental illness or stress, they can call upstairs and that person will come down and it'll be a warm handoff. We have pharmacy in the basement, and that means that if the patient wishes, we can send all the prescriptions there, and we can cover and help get very inexpensive medications for people. And there's actually some oncologists that are sending their patients to us as primary care, because then we can provide that kind of medicine that's outrageously expensive otherwise. We have social work. We have nurse clinicians who also can help coordinate care, and it's full spectrum care. So that's my ideal. And palliative care is not just for adults, it's for the family. And so what I love about it is that it's taking into account the whole person. The whole person. And I think that's critical, because everybody's different. And everybody has different goals. And we need to pay attention to that. Questions? Yes?
I'm just curious about.
Can we?
Or should we wait? Okay.
Thank you. Okay. So, Dr. Blank, what are the unique challenges when dealing with individuals with dementia?
Well, you've just heard the conversation about the palliative care thing, and those of you who've gone through your workbooks and seen the difficulty of making these kind of decisions as you've pondered them, I'd like to share with you the one thing about Alzheimer's or the neurodegenerative dementias, which are really neurodegenerative disorders. You've seen those pictures of the brain. The brain actually loses substance. And a lot of times, by the time people are receive that diagnosis, they may be at different points in that. And at some point, they are quite definitely not going to be able to make that decision. Even early, I'd like to read you some part of the 10 warning signs of Alzheimer's. Challenges in planning or solving problems. That's what you're being asked to do, plan, right? Difficulty completing familiar tasks. Decreased or poor judgment. Now remember, you're making end-of-life decisions and all of a sudden you have issues, right? Changes in mood and personality. And when I meet with people, one of the things that the caregivers will say, well, the person I can't talk to them anymore, and we used to be able to talk. So my pitch is that's why you need to do this now, far before, and this idea, well, I can do this and when something happens, that may be true with a cancer diagnosis, but with dementia, many times you're too far along in the process, or quite frankly, even if you're not far along in the process, you're not going to be able to make these decisions. It's going to be difficult. So that's why my big preaching is to get this done, and I frankly think when you're 40, you should start thinking about this as a minimum, because some dementia symptoms start in the mid-40s to early 50s. You never know, so think ahead, plan ahead.
Thank you. And Gail, you did hospice intake, as I understand. When is hospice appropriate, and what do they offer?
Hospice is appropriate when the physician certifies 6 months or less in a terminal illness. That's kind of a floatable time frame. It doesn't necessarily mean 6 months and your number's up. As a hospice nurse, I had patients for 18 months with a certain diagnosis, but there was always a going down scenario that we were documenting, and therefore Medicare was covering. Hospice is a very broad service. They have physicians. The hospice patient works with their own physician, but as Dr. Ammons mentioned, there also is a medical director through the hospice program. There is a nurse that's assigned a case, there's a social worker that is assigned. If the patient would like to have it, there's volunteers. There is also a chaplain assigned to the hospice program if the family deems spiritual care. There's music, thanatology, art, there's just a variety of services that is all covered. Medications are all covered. Bathing assistance, everything is covered by Medicare. If the person is not a Medicare aged, most insurances also cover it. Hospice can be provided in the home. It can be provided in a nursing home. It can also be provided in a hospital for the last terminal phase.
And now we are open to questions.
Okay, so my initial question was about the 6 months. I mean, it seems such a arbitrary number.
That's the Medicare lingo.
Gotcha.
6 months. And like I mentioned, the medical director and staff have to provide a diminishing patient response health-wise, and then they'll be recertified. So a person is recertified every 6 months? Is it?
No, actually,
3 months?
The way
Medicare set this up. Sorry. The question is, why 6 months in hospice? This is a number that I don't really honestly know where they came up with 6 months when they started this Medicare hospice program. But what we do when we admit somebody is we are asking, the team is asking, you know, would this person be alive in 6 months? And if not, then why? And we look at specific criteria that Medicare gives us. And we'll come up with a primary diagnosis, but we don't ignore all the other diagnoses that might be there. And it's really about the process that's a health process that's happening to the patient. Are they basically, I mean, they could die from the day you admit them to 18 months later. We don't really know, we don't have a crystal ball, but knowing what we do know, and knowing that they are declining and they have serious illness, our best judgment, medical judgment, is that they will not be with us in 6 months. And so they're admitted. Nurses, and nurse clinicians are awesome. They visit these folks at whatever their home is, whether it's home, whether it's a nursing home, whether it's their kid's home. And they shoulder a lot of the responsibility for following these patients. And so the doctors, though, this is why I'm saying this, the doctors have regulatory visits. So we write up a note, this is why they qualify, and then the first two, there's a 3-month and a 6-month visit by the doctor, and in between that, there's weekly visits, weekly meetings of all the team where we go through the patients and talk about what's going on. And then there's another, so 3 and 6 months. And each time this patient is seen by a physician, there's a decision, do they still qualify? But at that 3-month visit, we could say 6 months from there. Okay, so the important thing is, just as she said, we're documenting, are they continuing to decline? Does that make sense? Yeah. Did you want to add anything?
I'd just like to add one thing. With dementia, people have very episodic behavior, and they could look like they're near death, and a week later, everybody's wondering what the big fuss was all about. I think Dr. Ammons will agree that that makes it much more difficult to figure out what's going on. And just as a personal note, my wife was on hospice for 11 days.
Okay, question? I have a twofold question. One is palliative care. Who brings that up initially? Is it the doctor? You mentioned cancer. I'm a cancer survivor. My doctor never once mentioned it. So does it depend on the stage? And then can I ask the other question as well, or should I wait?
No, you can ask them both.
Okay. Does hospice, does that depend, the 6 month, when you guys start talking about hospice, does that depend on what they've signed for a pulse or anything, what their personal choices is for treatment?
Okay, 2 questions, and I'm going to answer the first one. And the first one was about who brings up the palliative care question. Well, palliative care has just become, in the last 5 to 10 years, an actual, we discuss this kind of thing for medicine. And, you know, my personal bias is that, like I said, my family's pretty darn healthy. There's a lot of us, but I think everybody should talk about advanced decisions. And that's really what you're doing. You may have cancer or be a cancer survivor, but that probably just gives you a little more insight as to what you would want, what kind of interventions you'd want, and who you would want as a power of attorney for medical or financial decisions. So palliative care, in my opinion, starting this discussion much earlier is important. And you're right, not all doctors go there. And it's a little difficult now because we are in a system that's broken, in my opinion, and we are given, as physicians, as primary care providers, we're given sometimes only 15 or 20 minutes. And so if we want a real discussion about this kind of thing, we actually have to book that time. We have to say, no, I'm going to put this much time into it. And that becomes difficult. What I tend to do is I tend to have people take home a 5 wishes. And I just say, just look at this. Bring it back. Let's talk about it. Talk to your family. And I just try and get a little crack in the door. And sometimes it's hard because there are people that are very, very afraid of death. And so it has to be a discussion. And so it's all time is needed. Can we answer her second question first? Yes, remind me. Post. Okay, so the post is most useful when you have a significant illness, significant decline, and you have very strong opinions about what you want to have happen to you, okay? We admit people that do everything on their post, and we grant them that, even though when they're on hospice, they likely would not do well with any of those interventions. CPR was developed to revive essentially young people who had a sudden event, not people who have multiple chronic illnesses. It doesn't work very well when you have multiple chronic illnesses. There's a very poor response, even if you're in the hospital. We're talking 3%. And we're not even talking about whether or not you come back and your brain's working, okay? So there's a lot of education that needs to happen. And I'm a real advocate for that. Does that answer your question? Okay.
Since I've already had it pointed out that I have a pulse, and depending on your opinion of me, looking at me, you either think I've jumped the gun or not. I'm 80, and I'm fully aware, my statistic is that 1 in 20 CPRs are effective in somebody my age. I have chosen, therefore, even though I'm in good health, I'm a 20-year cancer survivor, but I'm in good health otherwise, I have chosen to sign a post. I wear a do not resuscitate band on my wrist because I feel that when you're 80, your margin of error is much, much smaller. Therefore, I don't choose to take that chance. I'm going to go full out as long as I can, enjoy every minute of it. I initiated this 2 years ago after a discussion with my clinician. I'd have changed doctors if she hadn't signed it. I feel very strongly that I will not have a good quality of life, and that's what's most important to me.
I have to agree. I did it yesterday. I went to my doctor. He suggested it because he had talked to me about how things were going. And I went and I had somebody do the whole thing, fill it out for me, asking questions. I would suggest to everyone to do that because I'm close to 80 and it's all taken care of. And I did the pulse. I'm like you.
So we have a second vote.
Two questions. One is, what are the diagnoses? You mentioned there are 4 diagnoses that are currently being used in palliative care for you. And I'm really interested in knowing what they are.
The current program we have where we're doing a pilot with Medicare is they use congestive heart failure, chronic obstructive pulmonary disease, COPD, cancer diagnoses. I'm trying to remember the third one. They don't have dementia because dementia is complicated. I mean, it's so complicated, and everybody is very individual on how this happens to them. I'm sorry, I can't come up with the fourth one, but those are the basics because those are really common. You know, we're having people that get bypass surgery, maybe even as old as 80 sometimes. And honestly, that's gonna keep your heart ticking for 20 years, but it says nothing about your brain or the other parts of your body and your quality of life. So I honestly think that we should be talking about these things when we make these choices. Yeah, we're good at keeping people taken, but that doesn't mean they have a quality of life. So.
I might add that remember that people with dementia get other things. And that's another reason to that's just part of the process.
The other question is, what's the difference between polls and living well, or what's registered with the state as?
Well, the post is something that you sit down with your physician and go through, and it's all those. Do you have the page that it's on there? What page is that? If you open to page 33 and you look at those different sections on it, and you have discussion not just with your clinician, but your family is what I would encourage. And what you're doing there is at the bottom of it, you can see the doctor signs it. These are orders. And what I suggest to people is that some of them even post them on the door. Some of them put them right by the bed. I always hunt them. They're supposed to put them on the refrigerator. When I do a home visit, I always hunt them down. And I pull them out and I say, tell me what this is. And sometimes people don't even remember, if they're not in very good shape. But I always try to review it because those wishes might change. And if they do, we need to change it. Okay? So it's a way of just reminding us that things change. And those orders, I have people make copies and put them in their purse or their car, because if something happens in an accident or something, then people know what you want. And so I think that that's the main goal, is to make sure when those big 911 guys come in, the firemen or whomever, ambulance, that they don't start thumping on your chest if you don't want it. Okay? It does break bones, and sometimes you don't come back. Yeah.
Mine is on the refrigerator.
Mine is too.
So Dick, I too am 80, and did you initiate that discussion with your provider 2 years ago? And is that covered by Medicare?
Yes, and I believe yes. There is a code. Not a code, there's a Medicare code, I should say. And she was quite receptive.
What are the biggest surprises about families have about hospice?
Boy, that's a big topic. When I would go out to a family's home and I would say, your physician has asked me to come and describe the hospice service and I've got paperwork to sign you up, I think I've lost track on how many families would show me the bedroom that was going to be mine. Big misconception is that hospice tends to move in and take over. A big job of the hospice team is to educate the family or friends on how to care for the person through their various stages of terminal illness. And the nurses would strive to not ever have surprises, so we would get certain medications in the home and teach the family, if you start seeing give this type of medication, or call the on-call nurse and we will work through things with you. But I think that the word is getting out better for general practitioners that hospice is a program that supports but doesn't take over. but it's still hard for a primary physician to really talk to some patients and say, I think you're hospice appropriate. It's a difficult, depending upon the patient and physician rapport. I do think it's getting better, but it's still a long way to go. Would you agree? To a certain degree?
Yeah, it's better though.
Okay.
This is an odd question, but I work at Missoula Aging Services and we get asked about hospice. And I'm still learning about hospice in connection to everything. I always just assumed that all hospice was nonprofit. But anybody can hang a shingle and say, I provide hospice care. So are there hospice services that are for-profit? Or
Yes.
are all of them for-profit?
No. A person would need to do their own research. There are definitely for-profits and there are nonprofits.
Okay.
They're all going to provide very similar care, and they're all going to be funded by Medicare. It just depends on how each agency manages.
How do you,
Do you want to?
Yeah. Just,
I would prefer to give good information about hospice than unclear. So for me, that's an important question.
it is an important question, and you know, there basically I'm only going to add that to be a hospice, there are enormous regulations. There are nice checks and balances that need to be met, and this allows the hospices, whether they're for-profit or not, to provide excellent end-of-life care. Yeah.
With hospice, if you're considering it, is it common that you would interview 2 or 3 optional providers?
You mean as hospice providers? I would encourage people to do that. You know, I think a lot of what happens in medicine that needs to happen in any kind of level of medicine is that you need to feel safe, comfortable, and able to speak to the person that's caring for you. And that's true of the hospice, it's just a bigger thing. But usually we do try to have the primary care doctor that you have be very engaged with what's happening. So we don't take over, just like you were saying.
Can you give some concrete examples on how the palliative care team helps the family? So we can wrap our heads around that. Like, what are some of the things that palliative care may help a family or caregivers with?
Okay, well, again, it's similar to hospice, a little broader range. And we do try to have the primary doctor be the doctor, although we're always, and partners, Dr. Carla Davis and I are the backup. So if there's something that needs to happen right now, we're there for that. So, can you repeat the question?
Sure.
Speaking of
I'm curious
cognitive
like,
issues.
What are some concrete examples of
Oh,
how to
okay.
help a family member? Like,
Yeah.
someone
So,
who may have like extended leave and needs something signed.
right. Well, really, where the rubber hits the road on that is the social workers. And our social workers are fabulous. Well, all these social workers are fabulous at any hospice. And they go through not only just support with grief or loss, but they do the practical things. They talk about finances. They talk about other programs that could be accessed. And
Funeral arrangements?
yeah, they do.
What was that? Repeat.
Funeral arrangements. So they're very practical, and you know, for trying to find the optimum care situation, all the way from having somebody in the house 24/7 or different people coming in, to basically just needing some support intermittently. And so it's really variable. and they do a remarkable job.
I just, as another commercial, might add that the brief memory lapse that Dr. Ammons just did is not a sign of dementia.
We wouldn't want that.
No. But really, a lot of people will come in and say, oh, this happened and I must have dementia. No, you don't. We all do that.
Sleep deprivation.
That's the number. Yeah.
I just wanted to try to clarify, palliative care, when you are receiving palliative care services, you can still maintain your treatment options. And hospice, you pretty much aren't. So in other words, in hospice services, you're really not going to have exploratory surgery on your bowel. Palliative care, you may, because it's a holistic approach. And the palliative care is a very confusing thing. And what I try to begin to think about with some friends and family who ask me, I say, think of a common diagnosis like diabetes. That, you're palliating diabetes. You're never going to cure it. You palliate it with insulin or your oral hypoglycemics, your diet. That's kind of a real basic thing to start to think about. Of course, in the real palliative care that we're talking about, it's somebody who has been experiencing congestive heart failure or COPD for years and years. And the physician is seeing kind of a multiple hospitalizations or frequent more weight loss. There are signs that indicate they're not maybe hospice appropriate quite yet, but it's definitely indicated for palliative care. Does that kind of clear things up?
Yeah, so for example, if someone was doing chemo and radiation, they couldn't do hospice, but they could have a palliative care team.
Correct.
And then when
Yes.
chemo radiation stopped, then hospice could be part of
Right,
that.
right.
Is that right?
Correct. A real key component in the hospice program is that this just think of Medicare as being the primary insurance coverage. And so if your diagnosis is a cancer, but you have opted to stop your chemo, and now you're on the program for a month and you think, well, I'm gonna go back and do chemo. It would, I hate to be black and white, but it would basically break the budget. So if a person is on hospice and they opt to go back to chemo or surgery, we pretty much would remove them from the hospice program at that time.
I was going to say thank you. It's really important that you do understand that with hospice, typically the chemotherapy's failed. There's no other options, or not tolerated at all, and that does happen, okay? Or there's other diseases that are contributing to the decline that can't be reversed at all. And during palliative care, you can be in there fighting as hard as you can about a cancer diagnosis, or trying to maximize your medical management of congestive heart failure or poor lungs. And when you get to the point where it's just not going to work anymore and you're starting to decline, that's when hospice can be, you can be qualified for hospice.
So my question was with regard to hospice. What happens with people, with like isolated people with no family and no friends, or whose family and friends are all impaired themselves, chronically ill and not able to take on any more burdens? What happens with those people when they need hospice care?
Repeat that.
Repeat the question.
That becomes a social worker's nightmare.
I'm a social worker.
Oh, I'm repeating the question. What happens if a person is hospice appropriate and lives alone or has no family? Certainly reaching out for any extended family or friends to potentially help would be one thing. But most likely a social worker would look to place the person in maybe an assisted living or a nursing home, understanding that hospice cannot pay room and board for that situation. If that was the case and the person couldn't afford it, the social worker would work very hard to get them on Medicaid.
Not to belabor the point, but this is exactly the kind of individual that needs to do some planning ahead, needs to try to identify it, and when they're isolated, it's really, really a tough deal.
At what point, I mean, I know doctors, medical teams have to keep on keeping on trying to save a life, but if I don't have something filed with the hospital and my family member doesn't go there, do you guys have to continue on, or do you guys stop continuing, send a nurse? How does that go to find that I filed 5 wishes or a pulse or whatever?
Well, I would say that, first of all, that's the physician's biggest headache, is to be stuck in that position. You then are forced sometimes to make a life or death decision without, particularly if the patient is unconscious, without any knowledge. And it's really, really hard, and this again is why I think everybody needs to give themselves not just one, but several people, so that that doesn't happen. There just has to be somebody available. There are, at least in the hospitals I practiced in, there are teams that will deal with a crisis situation. I did a lot of trauma radiology. Sometimes somebody came in that had no family with them, was unconscious, was bleeding to death, and we could stop it. We would then make a phone call, and you're taking a risk when you do that.
One of the things that I have participated in, which I think is extremely helpful in these kind of circumstances, is ethics committees. So they are a resource for physicians when there is no family. And sometimes this is somebody who's homeless, and we don't have any connections for them. And so there is a committee that can be called upon by the physicians or anyone. It doesn't have to be a physician, a nurse, whomever. And we meet and discuss and review the case and give our recommendations. So that's one other level of discussion we can have.
Palliative care, though, they take a copy and it's online there. The hospitals have told me.
We will talk about that after the panel, how to register your desires with the state, and then doctors have access to it.
And also in another state.
Yeah, you can do it in state and more access. They can discuss it later, yeah.
I get to experience what this is like to hold all this. My name's Alicia, and I'm the education coordinator at Missoula Aging Services, where we promote the independence, dignity, and health of older adults and those that care for them. I want to say thank you to our panel, to Dr. Ammons, Dr. Blank, to Gail. Thank you so much for coming to answer all of these complex questions. I also, part 2 of our workshop today right now is being recorded by Missoula Community Access Television as part of a media assistance grant donated to Missoula Aging Services. So thanks to MCAT and to Ron, who's filming us right now. Yes, Stephen.
I just wanted to say that the information that the panel provided helps clear up my understanding of what I have to do to finish this.
That's great.
In terms of defining like 6 months for hospice and palliative care. So it kind of puts a scenario around when this comes into play. Does that make sense?
Thanks, it was successful, what
Yes.
we're hearing. Would anyone else like to share anything? Okay.
I've just got a little, I was given this by someone who dealt with a dementia problem. I thought it's kind of a neat note and keep it in mind. There is no real ending. It's just the place where you stop the story. Think about it.
Yeah.